Welcome to this deep dive on Rad-On Smart Review, our RadBio edition.
Glad to be here.
Today, we're really zeroing in on total body irradiation syndromes and also the initial effects of radiation on some key normal tissues.
That's right. Skin, the GI tract, and the hematopoietic system, basically, the bone marrow.
Exactly. So we'll explore what happens when the whole body gets a significant radiation dose, those acute syndromes.
And then we'll shift to how those specific tissues react, the kind of early effects we see more often during standard radiotherapy.
Sounds good. But let's start with the big picture. Total body irradiation, or TBI syndromes.
Right. TBI, it's not your everyday radiotherapy scenario, obviously. We're talking accidents, nuclear incidents, maybe terrorism.
Or in a controlled setting like conditioning for a bone marrow transplant.
Exactly. So understanding the sequence of events after TBI is, well, it's pretty crucial for anyone in our field.
Okay, so what's the first thing that happens?
The very first response is usually what's called the prodromal radiation syndrome. D-R-O-H.
Prodromal. Got it. And these symptoms pop up fast.
Very fast. Sometimes minutes, maybe hours after exposure.
And I assume it depends on the dose.
Absolutely. Heavily dose dependent. Higher dose means quicker onset, more severe symptoms.
What kind of symptoms are we talking about initially?
Mostly gastrointestinal stuff first. So anorexia, loss of appetite, nausea, vomiting.
And I remember reading that the time it takes for vomiting to start can actually be a rough guide to the dose received. Is that right?
That's a classic indicator, yeah. It varies a lot with the dose. Could be just minutes if we're talking about the cerebrovascular syndrome, or maybe, a couple of days for the hematopoietic syndrome.
And after that?
Then comes the latent period. This is tricky because the person might actually feel better.
Deceptive, right. They feel okay, but the damage is done underneath.
Precisely. And this latent phase can last anywhere from hours to weeks. Again, very dose dependent.
Okay, latent period ends, and then?
Then we enter the manifest illness phase. This is where the specific acute radiation syndromes, the ARS, really show themselves.
And these are defined by which major organ system is failing.
Exactly. And they are strongly, strongly linked to the dose received.
Okay, that sets the stage for TBI. Now let's switch gears a bit. Maybe zoom in on those early effects on normal tissues that we see more often in typical radiotherapy courses.
Good idea. So we're focusing on the skin, the GI tract, and the bone marrow, the hematopoietic system.
Because these are rapidly renewing tissues, right? They divide quickly.
That's the key. They have high cell turnover, so they tend to show radiation injury relatively early during treatment.
Let's start with the hematopoietic system, the bone marrow. Highly sensitive, I gather.
Extremely sensitive.
Yeah.
Because those hematopoietic stem cells are constantly dividing to make all our blood cells. Radiation hits them hard.
And there's a specific order in how the different blood cells are affected.
Yes, there is. First to go are the lymphocytes. They're the most radiosensitive.
How quickly do they drop?
It's dramatic. Within hours to days, their numbers can just plummet, even at doses as low as, say, 0.5 gray.
Wow, 0.5 gray, that's low.
It really is. Makes lymphocytes a useful early biological dosimeter, a dosimeter, and they're slow to recover too.
Okay, so lymphocytes first, what's next?
Next are the neutrophils, or granulocytes. You might see this weird initial spike first.
Oh yeah, the demargination effect, where they detach from blood vessel walls.
Exactly that. But after that brief spike, they start to fall. They reach their lowest point, the nadir, NIY, usually around 3 to 5 weeks after the radiation exposure.
And that drop, neutropenia, is what increases the risk of infection.
Correct. That's a major concern. Neutropenia, N-O-P-E-N-E, big infection risk. They do recover after the nadir, assuming the dose wasn't lethal.
Okay, lymphocytes, then neutrophils.
Then platelets, thrombocytes, thrombocytes. They follow a similar pattern to neutrophils, dropping after them and also hitting their nadir around that 3 to 5 week window.
Leading to thrombocytopenia and bleeding risk.
Thrombocytopenia, thrombocytopenia.
Oh,
yes. Increased risk of hemorrhage.
And finally,
the red blood cells, the erythrocytes, erythrocytes. These guys have the longest lifespan.
so anemia develops much more slowly.
Right. Weeks to months usually before you see significant anemia.
Okay, that covers the blood counts. Let's move to the GI tract, also rapidly renewing.
Very much so. Especially the small intestine. That epithelial lining replaces itself every, 3 to 6 days. Super fast turnover.
Making it highly radiosensitive too.
Definitely.
So how does the damage happen there? We talked about villi and crypt.
Yeah. Think of the villi as these finger-like projections that absorb nutrients. At the base of the villi are the crypts of Lieberkühn.
L.E. Burkun, those contain the stem cells.
Exactly. Those crypts are like the little factories producing the cells that migrate up to form the villi lining. Radiation primarily kills those actively dividing stem cells in the crypts.
And the mature cells on the villi.
They're actually relatively radioresistant themselves, but they don't live long. They get sloughed off naturally.
Ah, so if the stem cells in the crypts are gone, there's no replacement.
You got it. No replacement means the villi gets shorter and shorter, and eventually you get denudation, a loss of that protective lining.
And how quickly does that happen?
In mouse models, after about 10 grays, you see significant denudation around day 3 to 5.
And the consequences sound severe.
They are. Malabsorption, obviously. Malabsorption. You can't absorb nutrients or fluids properly.
Leads to fluid and electrolyte loss.
Big time. And then there's the risk of bacterial translocation.
Where gut bacteria get into the bloodstream.
Yes, potentially causing sepsis, sepsis, and endotoxemia. Endotoxemia. Really dangerous.
Is there a way to measure this stem cell sensitivity?
There is. The classic assay is the jejunal crypt cell assay. It measures the survival of those intestinal stem cells after radiation. The D0, which is a measure of radiosensitivity, is around 1.3 to 1.4 gray for these cells.
Okay. Hematopoietic system, GI tract. What about the skin?
Skin's interesting. It has early responding components, the epidermis, and late responding ones, like the dermis and vasculature. Let's focus on the early acute reactions for now.
Sounds good. What are the target cells for these early effects?
Primarily the basal cells of the epidermis. Those are the stem cells for the skin surface. And also the cells in the hair follicles. They're very radiosensitive.
Right. So what's the sequence of skin reactions we might see? Dose-dependent, I assume?
Absolutely dose-dependent, and there's a typical timeline. First, you might get an early transient erythema.
Erythema meaning redness.
Yep. Mild redness. Kicks in maybe 2 to 24 hours after just a couple of grays, maybe around 2 gray. It's thought to be due to capillary dilatation, dilatation.
Okay, transient, so it fades.
Usually. Then comes the main erythema reaction. This needs a higher dose, maybe around 6 grays or so.
And when does that appear?
Starts around 1.5 weeks after exposure. It's more intense, more persistent redness. Often feels warm, might be itchy.
What about hair loss? Epilation.
Epilation, epilation. That usually starts around 3 weeks post-radiation. Temporary hair loss can happen with doses around 3 grays.
And permanent loss.
You need higher doses for that, typically above 7 gray for significant lasting hair loss. It's due to damage to the hair follicle stem cells. Sometimes the hair might regrow, but maybe with a different texture or color.
Yeah.
Permanent loss also affects the oil glands, the sebaceous glands.
Okay. What happens at higher doses to the skin itself?
Around 4 weeks, if the dose is higher, say in the range of 7 to 14 grays, using standard fractionation, you might see dry desquamation.
Skin gets dry, flaky, itchy.
Exactly. It's the shedding of those damaged epidermal cells.
And if the dose is even higher,
then you can get moist desquamation. This requires a pretty hefty dose, maybe around 18 gray as a single fraction, or perhaps 55 gray total with standard fractionation over a decent-sized area, like 100 centimeters squared.
Also around 4 weeks?
Yeah, typically peaks around 4 weeks, too. That is where you lose the entire epidermis. The underlying dermis is exposed. It's raw, weeping fluid.
Sounds very painful.
It is. And a significant infection risk, too.
Can the skin heal from that?
It can, if the dose wasn't overwhelmingly high. Healing, reepithelialization, usually takes about 6 to 8 weeks. Surviving basal cells multiply and cover the area. You might end up with hyperpigmentation, though.
Darker skin in that area.
Right. There are also later reactions like late erythema, maybe 8-10 weeks out, or even secondary ulceration or necrosis with very high doses, but those are heading into late effects territory.
Okay, that gives us a good overview of the early tissue responses. Let's dive back deeper into those specific acute radiation syndromes, the ARS. We mentioned 3 main ones.
That's right. Hematopoietic, gastrointestinal, and cerebrovascular, or CNS syndrome.
Let's start with hematopoietic syndrome, sometimes called bone marrow syndrome. What's the dose range?
Typically kicks in with whole body doses between about 2.5 and 7 gray. But remember, we see blood count effects even lower, down to 0.5 gray.
And the LD50-60 falls in this range.
Yep. The dose lethal to half the people within 60 days without treatment is usually quoted as around 3.2 to 4 gray, right in that hematopoietic range.
Target organ is clearly the bone marrow.
The hematopoietic stem cells, specifically. Radiation kills them or stops them dividing. Mature cells die off naturally. No replacements are coming through.
And the timeline, prodromal latent manifest illness.
Exactly. Prodromal phase lasts hours to maybe a day or two. Latent period, maybe 1 to 4 weeks where they feel okay. Then the manifest illness hits as the blood counts tank.
And that follows the order we discussed. Let no patient relapse.
Let no patient relapse.
Yep.
Lymphocytes first, within hours. Then neutrophils and platelets hit their nadir around 3 to 5 weeks. Red blood cells drop much later.
And if the dose is lethal, what's the cause of death usually?
Typically infection, because of the severe neutropenia, or hemorrhage from the thrombocytopenia, usually occurs between 2 and 8 weeks, say 30 to 60 days post-exposure.
Treatment.
Supportive care is key. Good antibiotics, platelet transfusions if needed, and growth factors, GCSF or GM-CSF, to try and stimulate the marrow recovery.
Bone marrow transplant.
May be considered at higher doses, like above 7 or 8 gray. But at those doses, the GI damage becomes a major limiting factor.
Okay, that brings us to the gastrointestinal syndrome. Dose range.
Higher. Usually cited as around 7 to 15 gray whole body, though you start seeing significant GI symptoms around 6 gray. So there's overlap with the top end of the hematopoietic syndrome.
Target is the gut lining.
The epithelial lining of the small intestine mainly. Those crypt stem cells again.
Pathophysiology is what we discussed. Crypt cell sterilization, villi denudation.
Exactly. Mature cells slow off, no replacements, the mucosal barrier breaks down.
What's the time course here?
Prodromal phase hits hard and fast, severe nausea, vomiting, significant diarrhea, often within hours. There may be a very short latent period, just 2 to 5 days, where things might seem to improve slightly.
But then the manifest illness comes back.
With a vengeance. Around day 5 to 7, you get recurrence of severe, often bloody diarrhea, massive fluid loss leading to dehydration, electrolyte chaos, malabsorption, and that risk of bacterial translocation and sepsis is huge.
Cause of death.
Usually dehydration, electrolyte imbalance, or sepsis. And it happens faster than hematopoietic death, typically within 3 to 10 days, maybe up to 14 days.
Treatment.
Again, supportive care. Massive amounts of IV fluids, electrolytes, nutritional support, broad-spectrum antibiotics. But honestly, at full GI syndrome doses, the prognosis is extremely poor. The GI death usually happens before the full marrow failure would have killed them anyway.
Grim. Okay, the last one. Cerebrovascular syndrome, CV or CNS syndrome, dose range.
Very high. We're talking greater than 50 gray whole body, typically. Although you can see significant neurological and vascular damage developing above maybe 20 or 30 gray.
Target is the brain and its blood vessels.
Central nervous system and the vasculature, yes. The mechanism involves damage to the blood vessels, vasculitis, increased permeability leading to swelling, cerebral edema.
QLELASSADE-MU.
Right. Plus probable direct neuronal damage and inflammation. It's complex.
And the time course?
Extremely rapid. Prodromal phase within minutes to hours. Extreme nausea, vomiting, but also striking neurological signs.
Yeah.
Anxiety, confusion, ataxia, loss of consciousness, seizures.
The latent period.
Can be minutes to hours or basically absent altogether. It transitions very quickly into the manifest illness.
Which involves?
Rapid neurological decline, lethargy, somnolence, SOM no lens. That's extreme sleepiness, tremors, convulsions, coma, and finally cardiovascular collapse.
Cause and death here is very quick then.
Usually within 24 to 48 hours, maybe up to 72 hours. It's driven by that increased intracranial pressure, the brain swelling, and the cardiovascular system giving out.
Is there any treatment?
No effective treatment, unfortunately. Care is purely palliative, focused on comfort. These individuals also have lethal GI and hematopoietic damage, but the CNS failure kills them much faster.
And you mentioned overlap between these syndromes.
Absolutely. In that 6 to 10 gray range, you've got severe hematopoietic and significant GI damage occurring together. Above 10 gray, you have the full GI syndrome, plus essentially guaranteed lethal bone marrow failure.
And above 50 gray, all three systems are hit lethally.
Correct. And we shouldn't forget multiple organ dysfunction syndrome, MODS, or multiple organ failure, MOF. At doses above 6-8 gray, damage to other organs like lungs, kidneys, liver, contributes to the overall failure.
You mentioned lungs. Is there a specific pulmonary syndrome?
Yes, but it's generally considered a later concern. It develops weeks to months after someone might survive the initial hematopoietic or GI phases, especially with high doses or post-bone marrow transplant.
Radiation pneumonitis.
Pneumonitis, yeah. Typically around 10 to 16 weeks out, potentially progressing to pulmonary fibrosis, which is scarring, a major late complication.
Okay, that's a comprehensive look at the syndromes. Let's shift to some clinical pearls. What are the key takeaways for practice?
Well, in a potential mass casualty TBI scenario, those early signs are critical. Prodromal symptoms, especially time to vomiting, Any neuroscience plus that early lymphocyte count.
Crucial for triage and dose estimation.
Exactly. Helps you sort patients, triage, and get a rough idea of the exposure level, which guides prognosis and care.
And the specific ARS that develops tells you a lot about prognosis.
Huge indicator. Hematopoietic chance of survival with intensive care. GI almost always fatal. CNS uniformly fatal. It sets expectations.
Management follows from that. Supportive for hematopoietic, palliative for GI and CNS.
That's the essence of it.
All right, time for a quick board review section. Test our knowledge.
Let's do it. Fire away.
Okay, question 1. A patient gets an estimated 8 gray whole body dose. Initial nausea vomiting, then feels okay for about 5 days, then develops severe bloody diarrhea, dehydration, fever. Which ARS is this? A, hematopoietic, B, cerebrovascular, C, gastrointestinal, or D, cutaneous radiation syndrome.
8 gray. Latent period of 5 days. Severe bloody diarrhea. That sounds like classic C. Gastrointestinal syndrome.
Correct. The dose and timeline fit perfectly. Question 2. What's the approximate LD 50-60 for an unprotected human adult? A, 1 to 2 gray, B, 3 to 4 gray, C, 6-8 gray, or D, 10-12 gray?
That's the dose lethal to 50% in 60 days. It's B, 3 to 4 gray.
Right again. Question 3. The most radiosensitive circulating blood cell showing the earliest and most dramatic drop after TBI. A, erythrocyte, B, neutrophil, C, platelet, or D, lymphocyte.
Oh, that's definitely D, lymphocyte. They plummet first.
Correct. Question 4. Exposure 50 gray, rapid confusion, ataxia, convulsions, coma, death in 48 hours. Which syndrome? A, hematopoietic, B, gastrointestinal, C, cerebrovascular or CNS syndrome, or D, pulmonary syndrome.
50 gray, rapid neurodecline. Has to be C. Cerebrovascular or CNS syndrome.
Excellent. Question 5. Can you quickly recap the typical order of hematopoietic cell depletion after radiation?
Sure. Remember, let no patient relapse. So lymphocytes first and fastest. Then neutrophils and platelets drop, reaching their nadirs around 3 to 5 weeks. And finally, red blood cells decline slowly.
Perfect. Question 6. What are the primary cellular targets for acute radiation-induced enteritis, that gut damage? A, mature villus cells, B, smooth muscle cells, C, endothelial cells, or D, stem cells in the crypts of Lieberkühn?
It's those factories. D, stem cells in the crypts of Lieberkühn.
Correct. Question 7. A patient notices hair loss about 3 weeks after starting radiation therapy. What's the minimum approximate acute dose needed to cause temporary epilation? A, 1 gray, B, 3 gray, C, 7 gray, or D, 15 gray?
Temporary hair loss around 3 weeks. That typically starts around B, 3 gray.
You got it. Last one, question 8. What's the approximate single-dose equivalent threshold for developing moist desquamation? A, 6G GI, B, 10 GI, C, 14 GI, or D, 18 GI?
Moist desquamation, the really wet peeling. That's a higher dose, around D, 18 gray single fraction equivalent.
Fantastic. Pass the board review. Now, let's talk mnemonics and analogies. We used let no patient relapse for blood cells. Any others?
Well, the analogy for the GI tract damage is pretty useful, I think. Picturing the villi lining as a lawn.
Right. Constantly growing and being mowed by cell shedding.
And the crypts are the roots. Radiation kills the roots, the stem cells. So no new grass blades can grow, and the lawn just thins out and disappears. Helps visualize that denudation process.
That's a good one. Okay, let's bring this into clinical decision-making. How does this knowledge apply day to day?
Well, monitoring blood counts is routine during radiotherapy if we're irradiating significant amounts of bone marrow, right?
Absolutely. We watch those neutrophils and platelets closely.
And sometimes if we anticipate a big drop, we might consider using prophylactic growth factors like GCSF, PROHE-ALAC-TIC to try and shorten that period of neutropenia.
Makes sense. What about GI toxicity? Nausea, diarrhea?
Super common with abdominal or pelvic radiation. We use prophylactic anti-nausea meds, antidiarrheals pretty routinely. Sometimes nutritional support is needed, and recovery really depends on those crypt cells regenerating.
And skin reactions.
We grade them, educate patients constantly about skincare moisturizing, avoiding irritation. Severe moist desquamation is a big deal, needs intensive wound care, maybe even a treatment break.
So predicting these acute effects helps us plan treatments, set dose constraints, and counsel patients properly about what to expect.
It's all part of that therapeutic balancing act. Maximize tumor kill, minimize normal tissue damage.
Great. So let's try to summarize our deep dive today.
Okay. We covered total body irradiation syndrome, starting with those prodromal symptoms, then diving into the specifics of the hematopoietic, gastrointestinal, and cerebrovascular syndromes. We hit the dose ranges, timelines, target organs, and sadly, the causes of death for each.
And then we focused on those early radiation effects on key normal tissues. the hematopoietic system, lymphocyte sensitivity, those nadir timings for neutrophils and platelets, the GI tract, how crypt cell damage leads to denudation.
And the sequence from erythema and epilation through to dry and moist desquamation, tying them to approximate dose thresholds.
Understanding these acute responses feels really foundational, doesn't it? Both for, potential emergencies and just for managing our everyday radiotherapy patients.
Absolutely critical knowledge.
But as we know, understanding the acute responses is really just the beginning. Next time, we'll be delving into the late effects of radiation on normal tissues.
Yeah, the longer-term consequences.
Yeah.
So maybe something to think about is how these immediate and those delayed responses interact.
Yeah.
How does the body's reaction over time influence how we plan treatments and what the long-term outcomes are, especially for survivors of high-dose exposures? What are those lasting challenges?
That's a great thought to leave with. You can find more practice questions and resources over at radwonksmartlearn.com, and please subscribe to Radonk Smart Review so you don't miss our next deep dive.
Thanks for tuning in, everyone.